you can hear me very well. You are most welcome to this session of the WHO RSV Roadshow web series. It's the fifth one, and they've been running since last year, and there are two more to go. So you're most welcome to this session. I'm Emmanuel Mgisha, working with PATH, largely involved in new vaccine research as well as new vaccine introduction, and I will be taking you through this session. Yeah, so the Roadshow series, as I mentioned, they have been running since September last year, and there are two more to go. And we largely target the policymakers, the decision makers, immunization and maternal care, and the communities in the low and middle income countries. And the goal is generally to increase awareness of the RSV disease, the prevention options that we have at the table, the implementation strategies for informed decision making. And we have various resources that will be helping you to get more information around this topic. Yeah, so as I mentioned, this is the fifth one of the series. And today we are specifically looking at the immunization pipeline, global policy, and programmatic use. And so in terms of the housekeeping, we would want full participation, given that you've been listening to the most of the series that have been running. So we would want you to fully participate. We would want to get your comments and questions during this session, during the presentations, and the questions will be answered at the end of the presentations. We may not be able to answer all the questions, but we will refer to more areas where you can get more information. Please submit your questions and comments on the Q&A, not the chat. If you submit your question on the chat, unfortunately, we will not be able to see it. So please submit that on the Q&A. That's when we'll be able to see your question. So today we have special speakers who will be taking us through various areas. And we will have Dr. Erin Sparrow, who is a public health expert with 18 years of experience working at the World Health Organization. She specializes in vaccine development and infectious disease, and currently serves in the product and delivery research unit within the WHO Department of Immunization. And Erin will be taking us through a deeper dive into the policy pathways for low and middle income country markets for the licensed RSV immunization tools, and now recommended by WHO for global use. And then we will have another expert, my colleague from PATH, Dr. Jessica Fleming, who is an infectious disease epidemiologist and senior research scientist working in PATH's Center for Vaccine Introduction and Access, based in Seattle, Washington. And over the last 25 years, Dr. Fleming has worked on a continuum of product development, from ensuring public health technologies are designed appropriately for their introduction use, to conducting research and quantify their impact. And Jessica will be walking us through the key considerations for RSV maternal vaccine and long-acting monoclonal antibodies implementation. And last but not least, my neighbor here, Dr. Eva Nakabembe, who is a senior obstetrician gynecologist, clinical researcher, and academic based at Makerere University, Kampala. She's a clinician at Mulago Specialist Women's Hospital and Women and Neonatal Hospital in Kampala, Uganda. And she has more than 20 years experience working in Sub-Saharan Africa in different programs to improve maternal and child health. And she'll be giving us an expert opinion on the vaccines. Now, before I invite the speakers, I would want to remind ourselves that in the previous webinar event in this RSV Roadshow, experts have been providing high-level overview of the issues surrounding the urgent need for RSV disease prevention and other key topics. And the series feature PowerPoint presentations of various RSV prevention topics that WHO and PATH have developed with other collaborators on the RSV communication tool, which is free and open access to everyone here and anyone seeking to learn more information about RSV prevention and, more importantly, decision making as well as introduction. And so with that and without further delay, let me take this opportunity to invite Dr. Erin Sparrow to take us through her presentation. So Erin, you have the floor.
Thank you so much, Emmanuel. Just to confirm, everybody can still see that in presentation mode. Emmanuel, it looks fine on your end. I've just taken control of the slides. All right.
Yes.
Great, fantastic. So before I get started on the RSV immunisation policy and the pathway for low and middle income countries to access RSV immunisation products, I just wanted to highlight the burden of RSV disease in young children for those of you who maybe haven't been able to join the earlier webinars or who are less familiar with RSV. But RSV is actually the leading cause of severe respiratory infections and hospitalizations in young children globally. And in 2019, it was estimated to lead to 33 million episodes of acute lower respiratory tract infection, leading to 3.6 million pediatric hospitalizations and just over 100,000 deaths. And as you'll see on the right there, nearly half of all of those RSV-related deaths are occurring in infants before 6 months of age. And to put that into perspective, that accounts for 3.6% of the total mortality in infants younger than 6 months of age. 90% of the pediatric mortality due to RSV is actually occurring in low and middle income countries. This is because babies are dying often in the community before they actually reach access to healthcare, or when they are hospitalised, they don't have adequate access to the supplementary oxygen, for example. And so while RSV is a global burden and it's causing a lot of hospitalizations and an economic burden in high-income countries, it's really low and middle-income countries where the bulk of mortality is. RSV is also a seasonal virus, a little bit like influenza in temperate climates. So we see very distinct winter peaks of viral activity, but it does have year-round circulation in other climate zones, such as in mainly mainly tropical climates, but also subtropical climates as well. And because the two products that we now have available to prevent severe RSV disease in young infants are passive immunisation products, so they provide temporary protection against RSV, it's important that we think about how seasonality might need to be factored into policy decisions. And so the two products that we have available now are a maternal vaccine on the left there. This is delivered during pregnancy, but the aim is to actually protect infants from maternal antibodies for the first 6 months of life. So the mother will get the vaccine. It will boost her pre-existing antibodies that she's developed over a lifetime of exposure to RSV, and they'll get transferred through the placenta to the baby and protect that baby from severe infection for several months post-birth. The other product that is available is a monoclonal antibody. It's long-acting in the sense that a single dose will last for about 5 or 6 months and will protect an infant during their first RSV season. And that can be given directly to the infant at birth or just prior to or during their first RSV season. So both products are now licensed in many countries in the world and have started to be used. And since September, we now also have WHO global policy recommendations for all countries to introduce RSV immunisation products to protect infants from severe RSV disease. So moving on to the RSV immunisation pathway to global policy, and this is focusing on how we might see these products become available in low and middle income country markets. My presentation will cover the policy pathway, looking at the key drivers that affect vaccine introduction timelines for low and middle income countries. I'll provide an overview of what our strategic advisory group of experts for immunisation at WHO aims to do and what the global recommendations are for RSV. I'll also describe what WHO pre-qualification is and when we will expect these products to be pre-qualified. And I'll describe an impact study that's being conducted in Africa to provide further information on for policymakers on the prevention of RSV and health impacts in low-income settings. I'll also provide an overview of how we expect Gavi support to become available for RSV immunisation products. And then I'll describe some of the country decision-making mechanisms through NITAGs and the Ministries of Health. This map here highlights the current status of global market authorizations for RSV immunisation products to protect infants as of about midway through last year. And what you can see in blue is those countries that have licensed both products, so the maternal vaccines and the monoclonal antibodies. You'll see in green the countries that have authorised only the monoclonal antibody for the moment, and you'll see in red the countries that have only licensed the maternal vaccine. And what you'll see is that there are a lot of countries that are in grey still, and these tend to be low income countries. And unfortunately, what we have seen from a historical perspective is that new vaccines are introduced in high-income countries and upper middle-income countries much sooner than they are in low and middle-income countries. And this is partly due to a more protracted pathway in low and middle-income countries. So you'll see that the steps shown in blue are similar between higher income markets and low and middle income countries, but there are additional steps for access for low income country markets shown in green. And this is because higher income countries are self-financing. And so they will make their decisions independent of any external stakeholders, whereas low-income countries, and in particular Gavi-eligible countries, do rely on these external stakeholders to play a role in decisions around access in their countries. So these are SAGE recommendations, WHO pre-qualification, and financing support through mechanisms like Gavi or the PAHO Revolving Fund. So our Strategic Advisory Group of Experts on Immunisation, or SAGE, is the principal advisory group to WHO on vaccine policy. The committee comprises 15 independent members who serve terms between 3 and 6 years. They're completely independent of WHO. They're not WHO staff members. They're external experts in their field, and they need to be free of any conflict of interest. SAGE recommendations become what we call WHO vaccine position papers, which describe how vaccines should be optimally used in countries, what the target groups are, etc., what the dosing schedule looks like. And you'll see some examples shown there at the bottom of the slide. A SAGE recommendation is required by Gavi to finance the introduction of vaccines into Gavi-eligible countries. And it's also required for UNICEF because UNICEF needs to purchase pre-qualified vaccines, and a SAGE recommendation is a prerequisite to having pre-qualification of any vaccines. So a SAGE working group on RSV was convened in December 2023, and we spent most of last year with the working group reviewing and grading evidence on these immunisation products, the maternal vaccine and the monoclonal antibodies. And actually, the host of the webinar, Emmanuel, was one of our SAGE working group members. So we had him, I think, on 15 teleconference calls and a very intense 3-day meeting in Geneva to really just comb through all of the data in order to present some draft policy recommendations to SAGE in September, which were then adopted by SAGE. And so the high-level overarching recommendation from SAGE, which was made in September, is that all countries are recommended to introduce immunisation products for the prevention of severe RSV disease in infants, but the decisions on which product to introduce should consider cost, financing, supply, anticipated coverage, and feasibility of implementation within an existing health system. SAGE also recommended that both products can be co-administered with vaccines normally given at the same time. So any vaccines given during pregnancy can be co-administered with the RSV maternal vaccine, and likewise any vaccines that are co-administered, such as a birth dose of hepatitis B or BCG or first EPI visit vaccines or any routine vaccines can be co-administered with the monoclonal antibodies. In terms of seasonality, the recommendation was that year-round immunisation is preferable in most tropical or subtropical locations where RSV circulates for much of the year without any clear seasonality, or where seasonality patterns are not well described. And where RSV circulation has clearly documented seasonal peaks, seasonal immunisation may be considered based on programmatic and cost considerations. So those are the overarching recommendations, and they're summarised in the SAGE meeting report, where there's a link shown at the bottom of that slide. But we are in the process of developing a full WHO position paper, which will be published in April this year, that will have more of the details. But just some high-level details onto the recommendations for each of the products. For countries deciding to use the maternal vaccine, the recommendation is to give a single dose of that vaccine in the third trimester of pregnancy, as defined in a local context. So the third trimester of pregnancy generally starts at 28 weeks gestational age in most settings, but in some settings it might be a bit earlier, so say from 27 weeks. So we leave it a flexible recommendation for the third trimester to be defined in a local context. And we don't have any upper gestational age limit for the vaccination, except for pregnant people in active labour. For countries deciding to use the monoclonal antibody, the recommendation is to give a single birth dose to all infants at birth or at the earliest opportunity after birth if a year-round approach is adopted. With a seasonal approach, the recommendation is that the monoclonal antibody is recommended for all infants born just prior to the onset of the RSV season or during the RSV season. But we've included some flexibility for countries that may also opt to immunise older infants with the monoclonal antibody. So these are infants that are born out of the RSV season, they're born in the summer. Countries may decide that they want to immunise those infants when they're a little bit older, just entering their first RSV season. And that can be given up to infants aged 12 months. SAGE also noted at the meeting in September that they were really concerned about the supply and availability and high cost of the current monoclonal antibody, which they felt would limit global access. And I'll provide some more details about how we expect both countries to become available, both products to become available in low and middle income countries, particularly Gavi eligible countries. And now I wanted to just quickly touch upon WHO prequalification. So WHO prequalification, or PQ as we call it, is actually a program that started in the late 1980s at the request of UNICEF. And it really aims to provide an independent evaluation of the quality, safety and efficacy of vaccines and other immunisation products, such as syringes that are purchased by UN agencies. WHO PQ can facilitate immunisation product registration in low and middle income countries, but most importantly, UNICEF cannot purchase vaccines that are not pre-qualified by WHO, and Gavi cannot fund immunisation products without PQ being in place. In addition to ensuring that the quality of vaccine is up to standard, there's also a programmatic suitability requirements that need to be met for pre-qualification. And so mandatory criteria must be met. And there are also critical criteria which should be met, but there can be exceptions on a case-by-case basis if there's really a need and one of the critical characteristics hasn't been met. So some common considerations for programmatic suitability include auto-disable syringes. So the vaccine must, if it's a pre-filled syringe, it must be auto-disable, meaning that it cannot be reused. They must include vaccine vial monitors. So this is to confirm that vaccines have been maintained within the cold chain. And if they haven't, then they should be discarded and not used. There's also programmatic considerations around standard dose volumes and around standard storage requirements. And there are more than 150 vaccines that have been pre-qualified to date. So what happens during the WHO PQ process? So a dossier is submitted to by the manufacturer. This contains all of the data from preclinical testing, clinical testing, as well as manufacturing data. This is basically the same information that will have been reviewed by the National Regulatory Authority. And a product cannot be submitted for WHO pre-qualification until there is a National Regulatory Authority authorisation in place. And it can't be just any national regulatory authority. It has to be a national regulatory authority that is reaching WHO's maturity assessment level of 3 and above. If it has been licensed by what we call stringent regulatory authorities or SRAs, the PQ assessment is very fast, and often PQ simply accepts the assessment made by the stringent regulatory authority, such as the US FDA or the European Medicines Agency. And if it is a non-SRA, but the NRA is maturity level 3 or above, the process can include some additional assessments, including testing of vaccine samples and a site audit of manufacturing facilities. So because of the difference in SRA and maturity level 3, the timeline for pre-qualification can span anywhere between 90 days to 270 days, and also needs to factor in some back and forth with the manufacturer in case there's additional questions that need to be clarified. Another important ongoing area of work that's in process is a maternal RSV vaccine impact study that's moving forward in 4 African countries. This was actually requested by SAGE in October 2022 because they were concerned that the pivotal studies that were currently ongoing did not include enough representation from low-income countries, and because the clinical studies had very strict exclusion and inclusion criteria. And so it was felt that an impact study would better help inform low-income countries about whether to introduce RSV immunisation products. So the study is being led out of the Wits University in South Africa, and it also includes 3 Gavi-eligible African countries, the Gambia, Ghana and Kenya. And it's a more real-world randomized control trial that will have fewer exclusion criteria and aims to better look at the full public health benefits of RSV prevention in low-income country settings. So the primary outcomes for this impact study is to look at RSV-associated and all-cause severe lower respiratory tract infection and hospitalizations, as well as to look at preterm birth and low birth weight, and the study will start this year, and data will be available for Gavi countries by the time a Gavi financing window opens. So over to a brief slide on how we expect Gavi support to happen for these RSV immunisation products. For those of you who don't know Gavi, it's an international organisation that was created 25 years ago, really with the aim to improve access to new and underused vaccines for children living in the poorest parts of the world. And as of 2024, there are 54 countries that are eligible for Gavi support. So Gavi actually approved RSV prevention in infants as part of its vaccine investment strategy in 2018. And this was for the period 2021 to 2025. And this was based on 5 criteria needing to be met. So availability of a licensed product, WHO pre-qualification, SAGE recommendation, that the cost of the products would be within a predicted price range, and that Gavi would have available funding to support rollout to Gavi-eligible countries. And so far,
if you could please summarize.
Oh yeah, so far the first 4 criteria have been met, and so for the maternal vaccine that is, but there is a Gavi board decision taking place in June 2025 to reconfirm support. So we're hoping that will move ahead. I'll be quick with this slide. This just shows a timeline on the potential availability to Gavi-eligible countries. You're seeing the green dotted line is where we are now. So we have products, they're starting to be used in high-income countries and some upper middle-income countries. We have SAGE policy recommendations. The single-dose vial pre-qualification for the maternal vaccine is expected in Q1 this year. A multi-dose vial has been developed by Pfizer. That will be submitted for PQ in 2026, and that has price commitments for Gavi. So that will then open the UNICEF tender and allow potentially Gavi rollout to take place starting late 2027 and into 2028. Monoclonal antibody, unfortunately, we haven't got any price commitments. The product presentation is not suitable for pre-qualification, so that timeline remains unknown. But there is a second manufacturer that is entering the market this year, and so the price of the monoclonal antibody may come down. So we're watching that space closely. Very quickly, just to mention that pooled procurement mechanisms can also bring down the costs of vaccines, and the UNICEF Supply Division and PAHO Revolving Fund are already considering RSV. So the tender for UNICEF Supply Division will open up following WHO pre-qualification of the maternal multi-dose vial. And the PAHO Revolving Fund has already reached an agreement for maternal vaccine, and they will begin rollout of that vaccine to PAHO countries in 2025. In terms of the country decision-making bodies that will be involved in deciding on whether or not to introduce vaccines in low and middle-income countries, national regulatory authorities will need to first authorise the products. There'll also be reviews by RITAGs. These are regional immunisation technical advisory groups. Some RITAGs have already recommended RSV immunisation products. Some are starting to review the evidence this year based on the SAGE policy recommendations. And then there'll also be the need for NITAGs where they exist to make decisions to inform their policymakers about whether to introduce RSV immunisation products from a national context. But ultimately, it will be up to the government to decide on whether to introduce RSV immunisation products. And those decisions will be made in the context of limited budgets and competing health priorities. And so just to wrap up, what we've seen from a historical perspective is there has been a lag in the availability of new immunisation products in low and middle income countries, due in part to this more protected policy pathway that I've described. We will see a delay. I mean, the best sort of case scenario is that we'll see Gavi eligible countries introduce these products at the end of 2027. And we saw high income countries start to introduce these products in 2023. So WHO plays a role in the policy pathway through two main mechanisms. The SAGE recommendations, which have been achieved in September 2024, and pre-qualification. And this is in process for the maternal vaccine, but has yet to happen for the monoclonal antibody. Gavi provides the necessary funding for introduction of new vaccines and immunisation products for Gavi eligible countries. And procurement agencies have an important role to play to support affordable prices through pooled procurement mechanisms. But ultimately, it's NITAGs and the governments in countries that will decide on whether or not to introduce RSV immunisation products. And with that, I'll hand it over to Jessica Fleming, who's going to talk a little bit more about some of the programmatic use considerations. Over to you, Jessica.
Okay, thanks, Erin. So as Erin mentioned, I'm going to talk through some of the key issues that are relevant to implementation of these RSV immunization products with a focus on low and middle income countries. And then I would get to the next. Let's see. Okay, great. So here's my agenda here. So I'm going to first introduce the product options and talk through how their implementation can benefit from long-standing public health platforms, but then also highlight adaptations that may be needed to scale the products effectively. And I'm also going to cover relevant drivers of increasing awareness and also preparing healthcare workers for these interventions. And in the end, I'll highlight some work that's underway to fill some remaining gaps. Sure, how am I advancing? Oh, there we go. Okay. All right. So to start, as we know, there are two approaches to protecting young infants against RSV. The first is maternal immunization, which is vaccinating a woman during pregnancy, and then long-acting monoclonal antibodies, or MABs, we call them, that are administered to the infant. Both products are designed to provide passive protection, as Erin mentioned, through antibodies. We're protecting the infant. The characteristics of both products are here in this table. So both are given as a single dose. They're both provided in pre-filled syringes. The maternal vaccine is lyophilized or freeze-dried, and it requires reconstitution with a liquid, while the monoclonal antibody is already in a liquid presentation. While the maternal vaccine is currently available, as Erin mentioned, is in a single-dose presentation, a multi-dose vial is in development and is anticipated to be ready for WHO pre-qualification in 2026. And then again, both products provide 5 to 6 months of protection for the infant. Both RSV maternal vaccine and long-acting MAB products will have features that low and middle-income country immunization programs are used to seeing based on our long experience providing tetanus-containing vaccines to pregnant women and birth dose vaccines such as BCG, oral polio vaccine, and hepatitis B to newborns. These include vaccine procurement and management, as Erin was mentioning, through the EPI pathways, and a requirement for standard cold chain, which is 2 to 8 degrees Celsius. Again, both products will be provided through intramuscular injection, and they can also be administered with other vaccines. Some features, as Erin mentioned, required to meet WHO PQ and other programmatic suitability needs have not yet still been met. So for example, those vaccine vial monitors that measure cumulative heat exposure. And then also WHO recommends that products are presented in or paired with auto-disable or reuse prevention syringes for safety reasons. Now, while procurement and logistics will likely be similar to other vaccines that we've used, introducing these RSV products may require some new approaches or ways of doing things. For the maternal vaccine, a key implementation nuance is having what we call an administration, a very defined administration window. So unlike the flexible timing with which tetanus vaccine can be given during pregnancy, WHO recommends that maternal RSV vaccines be given in the 3rd trimester of pregnancy, as defined in the local context. So in many places, this is from 28 weeks of gestation onwards. And again, as Erin mentioned, there's no upper gestational age limit, but administration of the vaccine is not recommended during active labor. Now, some countries that are currently using maternal RSV vaccines have more strict administration window recommendations. For example, the US and WHO's PAHO region recommend between 32 and 36 weeks gestation. In the European Union, it's 24 to 36 weeks, and the UK, it's from 28 weeks to birth. But WHO's more flexible timing for giving RSV vaccine really recognizes the key to reaching women at appropriate time and providing protection to infants is the ability to accurately measure gestational age. So this can be difficult in some areas where there's limited or no access to ultrasound early in the pregnancy, and tracking last menstrual period is not done regularly. While these timing recommendations are coming from SAGE, WHO's other critically important programs that focus on maternal and newborn health have their set of guidelines around timing for antenatal care. These were updated in 2016, or shown here in this table on the left. The guidelines include 8 recommended antenatal care contacts over the course of a pregnancy. Now, the good news is that SAGE's gestational age recommendations overlap with the timing of 5 of the 8 recommended antenatal care contacts. So this provides multiple opportunities to vaccinate pregnant women when they're coming to receive routine antenatal care as per the schedule. Fortunately, even if there are delays in care seeking during pregnancy, later A&C attendance, even a first visit in the 3rd trimester, still aligns with WHO vaccine recommendations. Now, for long-acting MABs, timing is also important. The best protection is achieved when vaccination occurs as early as possible in the infant. So countries will need to consider how to reach babies as soon after birth, during or just before the infant's first RSV season. It'll be particularly important to plan specifically for reaching those infants who are born outside the formal healthcare system, as those are often the most vulnerable. As Erin mentioned too, seasonality may come into play. WHO's guidance for RSV is for year-round vaccination in most countries, especially, as Erin mentioned, in the tropical and subtropical countries where RSV circulates most of the year, or seasonality patterns are not well described. So here you can see this in the pink and orange. These areas typically see year-round virus circulation, so it makes sense to offer the vaccine throughout the whole year. A seasonal approach may be more appropriate in more temperate areas if immunization program capacity exists. But noting that RSV circulation can vary year to year, which can add complexity to seasonal prevention efforts, especially since the vaccination should start several months before the RSV season starts. And for the maternal vaccine, we also need to consider that gestational age in relation to the RSV season. A seasonal approach may be more cost-effective, especially for long-acting mAbs whose product costs are higher, but the start-stop nature may add some complexity to the implementation planning. Now, RSV will be a new disease target for many low and middle income countries, and as such, levels of awareness and knowledge will likely be low initially about both RSV as a public health problem and the availability of new prevention products. So awareness needs to be raised at multiple levels. And I'm happy to point out that by attending this webinar, we're all contributing to the global advocacy and communication efforts around RSV, is just understanding the problem and the solutions. Now, generating demand for these products at a national level will require clear country-specific strategies to inform the public health case for RSV prevention. And this includes, here in the pink box, prioritization decisions, implementation strategies, and raising demand and ensuring acceptability and strong uptake. Now, clarifying the urgency of RSV prevention will be especially important in low and middle income countries where, as Erin mentioned, external financing may be needed, the vaccine landscape is crowded, and health systems are already stretched thin. Key stakeholders at the national level are kind of the usual suspects, those NITAGs, or National Immunization Technical Advisory Groups, ministries of health, NGOs, and professional organizations such as OBGYNs and pediatricians. And of course, critical to engage at subnational level are health workers who would both administer the vaccine and are key advisors to pregnant women, as well as pregnant women themselves. Now, preparing the workforce will also be key to successful implementation. This is especially true when it comes to ensuring that antenatal care and expanded program on immunization workers operate in conjunction with each other and as they take on new responsibilities. So healthcare providers are in positions to greatly influence the knowledge, perceptions, and service experience that pregnant women and communities will have around RSV immunization. So ensuring that these healthcare workers receive the training and support they need will be critical. So for maternal immunizations, this may require additional training on vaccine administration and reporting for health workers who maybe are not accustomed to providing injections. It'll also mean preparing for those nuances like estimating gestational age and ensuring that women are reached during the appropriate vaccine administration window. For mAbs, this may mean preparing healthcare workers to confidently answer questions about monoclonal antibodies, which may be a new technology. Now, for both products, it'll be important to provide workforce education around RSV disease and prevention options, and support health workers' own acceptance and trust in the interventions so that they can confidently recommend them to their patients. Healthcare workers will also need to understand new reporting requirements. With the addition of another service, will need to help navigating a potentially increased workload. Now, a lot of work has been done in preparation for where we are today. A comprehensive gap analysis and roadmap that include implementation issues was done several years ago. And a value profile for RSV vaccines and monoclonal antibodies was also recently published. But there's several ongoing initiatives underway to continue to gather evidence, raise awareness, and fill any of those remaining implementation gaps. There are several partnerships that are focused on supporting an MI platform, so not just for RSV, but for other maternal vaccines, potentially Group B streptococcus, other things like Mpox. and preparing also for introduction of RSV in low and middle income countries. As Erin mentioned, there is an RSV vaccine impact study ongoing. There have been multiple health economic studies that have been conducted that are estimating the cost of RSV illness, the cost of vaccine delivery, cost effectiveness of prevention products, and also an estimate of the broader benefits of maternal immunization on maternal and infant health. Also, there's ongoing research on vaccine acceptance and delivery feasibility and readiness, and vaccine monitoring and safety. So some of the key highlights and key takeaways of my presentation. First, I wanted the products themselves. I want to note that they have similarities to existing maternal and birth dose vaccines, but there are nuances that will need to be addressed, including that gestational age administration and the potential seasonal delivery. Now, while there's a long history of experience to build on, implementation of both products are likely to require some system adaptations, including strengthening coordination between the immunization programs and the maternal child health programs, and supporting reporting and safety monitoring, which will be the topic of the next webinar in this series. Similar to any new vaccine, increasing awareness of RSV disease and the new products, social mobilization and preparing the workforce will be important to support demand, acceptability, and uptake. And then, as we just saw, there are multiple efforts underway to support introduction preparedness and help answer outstanding implementation questions. The success of RSV immunization will depend on continuing to build on these efforts in ways that meet the needs of individual countries. And then this was my last slide. I just like to end on a message of hope, really. For the first time ever, we have tools to protect infants from severe RSV disease, and we have the chance to bring about substantial public health improvements. But shortening that timeline for availability of these products in low and middle income countries where the need is greatest will require overcoming barriers to access, affordability, and implementation. And that will take work, coordination, and venturing into new territory in some cases. And countries will need to consider how RSV prevention could fit within their public health agendas. We all have a role in this, and by attending this webinar, you're already playing a part. So thanks for joining us, and I'll now turn it back over to our colleague, Dr. Emmanuel Mugisha. Thank you.
Thanks so much, Jessica, for that presentation. And thanks so much, Erin, as well, for the presentation. I think that's very good. Again, I remind you, participants, to submit your questions through the Q&A. I haven't seen some of the questions. I hope you are listening and following. I would love to see questions and comments on that. So now let's turn it over to Dr. Eva Nakabembe to give us her expert opinion on what has been presented. Dr. Eva Nakabembe, you are most welcome.
Well, thank you, Erin, and thank you, Jessica. I think first I'll give a disclaimer that I'm not a robot. I exist somewhere in a hospital in Africa, but you're going to allow me to turn off my video, but you will know it's not a robot. Someone is somewhere talking. But again, hello, everyone. And this is really a very rich webinar, and I'm very excited, especially when you talk about ultimately RSV vaccine is going to save life if it's given by us, the frontline healthcare workers, that it's ending up into the mom's arms. And I think for me, it's going back to the Sustainable Development Goals, you know, the stagnated neonatal mortality and infant mortality, and the bottom line of data-driven solutions, you know, to inform policy positions and to inform practice. So looking at this comprehensive, robust data around maternal RSV vaccination makes me think three things. For those of us in the low and middle income countries, I think the first thing is it a problem anyway? Because we have so many health competing priorities. And looking at the burden of mortality, I think you've reminded us that 98% of the pediatric RSV mortality is in low and middle income countries. And as you presented, I was telling myself, the vaccine should be here. It shouldn't be somewhere in an high-income country, but I think this makes us reflect, especially because finally, when we've gone through that long, protracted pathway to accessing the vaccine, it's us making sure that we talk about the available data and unpack it for our communities who may not be able to read a graph, to understand the pipeline of manufacturing. So as people who have attended this webinar, it's to reflect. And in line with maternal immunization again, if we are to reduce infant deaths, we have to look at those who are more vulnerable to severe disease, to death, who are infants under 6 months. But we've been able to, at least for some of the work we've done here in Uganda, that even if you looked at the infants under 6 months, it's babies under 3 months, meaning that RSV maternal immunization will be a big, answer, one of the answers to our stagnated neonatal mortality. And just, as I conclude my reflection, it's 4 things: vaccine confidence. When we have all this, our populations, how they be able to say, yes, we know this vaccine is safe. It's been thoroughly researched. There's been a lot of work that's been done prior to us accessing this vaccine, and financing, which is always not a given. I think I'm really impressed by the bit of feasibility of implementation within the existing healthcare system, because that's always a big concern for us. And for those of us at the front line, is it another visit that I need to tell a mother to come? But for RSV, knowing that it's going to be routine within the existing antenatal care schedule, I think that is really important. And I think I know there are colleagues on the call who are from the Ministries of Health, or as issues of procurement. So I think the opportunity that's within the EPI pathways and storage does not require, like we say in COVID, initial vaccines, new vaccine, and they're like, oh, you need a minus 80 degrees. We didn't even look there. But knowing that it can work within what we have, I think for me, that is a very important aspect of RSV vaccine. Excited to know about the real world phase 3 trials. And I think I just want to really applaud SEG members, maybe they are on WHO. I think, thank you for giving a shout out for us, because I think that makes us know whether that is really feasible for us in our real world with our numbers. And we really look forward to getting that data. So again, just to say that this is very important. And for those of us at the front line, we look forward to getting the vaccine through and ultimately making this a reality for our mothers, and most importantly, for the infants, the newborns, and the children under 6 months. I think that's what I can give us my reflection for now, because I know we may short on time, so we may need to hear from the audience. So over to you, Emmanuel. Be glad to take it.
Thanks so much, Dr. Nakawembe, for those reflections. And indeed, those are very important issues that you raise, very important in our situations and environments, and key considerations. So thanks again for the presenters, Jessica and Erin, with those highlights. I think that was very good. I again haven't seen any question in the Q&A. I don't know if everything has been very clear and well understood, or it's something that you already knew. I know we've been having so many series, and so it's not surprising, but we still welcome comments and questions in case you have them. This would be good for discussion. But now that we have 10 minutes to go, and I know I rushed Erin through, and of course, Jessica also was rushing through. I don't know if there's some more information or other things that you may want to share in detail with this here as before we get to the conclusion. So I give the floor to you, Erin, first.
No, thank you, Emmanuel. No, you didn't rush me too much. I made all of the main points that I wanted to make. But what I do think is really important to emphasize is I think this June Gavi board decision around whether to reconfirm commitment for an RSV maternal immunisation program for Gavi-eligible countries is going to be really, really important. And without having that, I am afraid we're going to see huge inequities in access and the immunisation products not reach those babies who need it most. So I just wanted to stress that I think we should all be sort of keeping our eyes on what's happening at the Gavi board in June. Jessica, did you have any further reflections?
I think just that the work that's ongoing around implementation and really understanding what it's going to take to get these vaccines, if countries decide, yes, we want to introduce, there are, as I mentioned, a myriad of different questions, but it's, some of them are, do you provide the vaccine through the antenatal care system, or do you focus on an EPI system? I think most people, or most, as we've worked in this field, most people kind of assume that the antenatal care system will, the vaccine will be provided through the routine ANC. But I think for some countries, it may actually, their systems are set up so that, well, maybe a mother comes to receive routine antenatal care, she gets informed about the vaccine, but she actually has to go down the hallway or to another building over, or come back for a routine immunization session. So I think countries are going to be able to think about how these vaccines are going to have to think through how does it best fit their situation as they have set it up. But again, I think my big stress too is that these are not wildly different products. We've been vaccinating pregnant women for decades with tetanus, diphtheria. We've got even COVID vaccines. So, and we've learned a lot through those experiences. So I think it's not something that's brand new that should be totally overwhelming. It's more about, okay, well, this is a new vaccine, but we've got a lot of experience. We've got a lot of things that are already set up. How do we make that fit within our own context so that it makes it work for us? So I think just even in this work, I'll also say that, I've been working in this almost a decade now, and just, we used to kind of think of maternal child health was here, immunization was here, and it was kind of siloed in people's minds. I think already we're reaching across that aisle and talking, we're talking to colleagues that are working, we're all working to better, health of both pregnant women and infants, newborns, children. And it's just been really a rich collaboration between the two groups. And I think this is just another opportunity to continue with that. So that would be my last reflection. Thanks, Emmanuel.
Yeah, thanks, Jessica, and thanks, Erin, for those reflections. Indeed, very important reflections, because all in all, what we are trying to do is make sure that we reduce the delay, the time lag between the time that we have this particular product and the time it gets introduced in the RMICs. But also, it's very important to be very clear and understand the mechanisms and all that. And that's why we are having these discussions, to kind of have ideas, exchange ideas, and hear from people in the field about how they feel, how this would move. And so people like Dr. Eva in the field, they would be very helpful in terms of guiding, especially the EPI around this delivery of this, because this is the time actually to look at a very close integration of these programs, maternal and child health, as well as immunization programs to work together. Again, back to the participants, anybody, in case you had challenges writing what you wanted to ask, do you have anything that you might want to raise verbally? I hope there's an option for that in this.
There is one question in the chat now, asking Eve to speak from her perspective on workforce training to prepare for RSV immunisation. I don't know if
Go
you
ahead
saw
and
that.
respond to that. I seem not to see it, but go
Oh,
ahead.
so- So is that a question regarding what appropriate training?
Yeah, from your perspective, what kind of workforce
Yeah.
training would be needed to prepare for RSV immunization? And get this is from the perspective of maternal vaccination and maternal healthcare workers.
Yeah, absolutely. Thank you. That's an excellent question. And I think what I would respond is sometimes when we are going through the phases of vaccine preparation, doing the clinical trials, we also have to consider introducing some of these messages, even in medical schools and nursing schools. Because if you didn't hear about that notion of maternal immunization during your training, and then you find it in the hospital, you always refer back to, okay, I didn't read around that when I was training. And then in practice, in service healthcare workers, new updates. And these updates really, many times, one of my reflections quietly here was key steps, like, for example, WHO prequalification, which sometimes for us locally, when it comes to, can you give us local context data, you may find like a regulatory body, research and ethics, will ask you for WHO pre-qualification. And you're like, okay, I don't have that yet. So in terms of training, we have to know how all the different facets of this work build into each other. Preclinical training, pre-service training, in-service training, but also giving updates to the senior healthcare workers through health professional bodies, FIGO, EXACOGS, East Central Southern Africa, or Asian bodies of obstetricians and midwives, because those are already experts who may not necessarily get the new updates. So being very intentional in which kind of audiences we are giving the updates to and we are training. I think that would be my response. Thank you.
Yeah, thanks so much, Eva, for that response. And indeed, I support your view that sometimes when we are introducing new vaccines, we forget the key audiences. But in this particular case, it's definitely very critical to have all those critical stakeholders involved, aware, about this particular product, about the vaccine, so that they can provide support and be the voices for the vaccines. Even if they are not the voices, but at least they don't oppose or begin asking, what is this and why is it there in front of the other people that actually expect answers from them, so that we can avoid that, especially some of the cases that might have happened during COVID. Not so sure if there is any other question. We have 2 minutes, perhaps. Let's just have your very final remarks. Erin?
Thank you. No final remarks from me, except to say thank you for joining, to everybody that's online, and just to keep an eye out for the final 2 Roadshow webinars, which are scheduled in February and March, one on surveillance and one on immunisation of older adults.
Okay, thanks. Jessica?
Yeah, and thanks everybody really for joining and spending an hour with us. Both Aaron and I and all of us here on the panel can be reached if you have any other questions. So please don't hesitate. I think there's an email somewhere maybe in the first part of the deck. So please don't hesitate to reach out, but really appreciate your joining. Thank you.
Dr. Nakabembe.
Just looking forward to finally having this vaccine given to the moms. We'll be excited to have it. Thank you so much.
Yeah, thank you so much, the panelists. Thanks for sharing quite a lot of informative aspects. And thanks so much for the participants for really taking time to listen into this. And as we mentioned, this is not the last one. There are 2 more. And also, we also are providing resources through this website so that you can get more information and engaged. So we really want to thank you for this, for participating in this. But also would like to request you to fill an evaluation form for this particular webinar. This is very important for us to get your feedback and be able to fine tune the next webinars. And yeah, so here's the poll. So please you can go through it as we conclude this. So, and with that, I would like to really thank you. I thank the organizers for this, and I thank the everyone who has really made this event very successful. And to the participants, please, let's see you at the next webinar series. Thank you so much, and have a very nice day and evening and night. Bye for now.
Thanks, Emmanuel.
Thank you, everyone.
Thanks.